Assalamu alaikum, ladies and gentlemen. My name is Omar Ahmad. I'm an intern from 12th batch, and today I'll be giving you guys a MSI pharmacology session. It'll be brief, inshallah. I'll try to give you as much information and help. And if this doesn't help you as much or you're still confused about anything, you can email me here or text me on WhatsApp. I'll be happy to help you, inshallah. So let's dive right into it. We have a few sessions, sorry. Uh, so so let's start off with osteoporosis drugs. That's the first thing we have. Osteoporosis, extremely easy. Pharmacology is one of the easiest subjects in the history of medicine. You just got to keep that mentality, and inshallah, everything will be easy for you. So, as usual, pharmacology, we got to know a few things. We got to know one, the mechanism of action. First, of course, we know the name of the drug, any class it is. If you know the class, it becomes easier because then everything under that is going to have a similar mechanism of action, similar side effects, etc. So, like I said, class, medication name, mechanism of action, any unique side effects. It's always the unique side effects that are going to be asked. Everything has nausea, vomiting. No one's going to ask you about that. So let's dive right into it. I made you a summary table with a few drugs. Okay, so we have the bisphosphonates is the most high yield, the most important, the most common medication used in osteoporosis. Uh, Now, although these tables I made might look big, remember you just take them step by step, okay? Take them one by one, read everything, every word, and try to understand every word one by one. You'll see all of these words, they're so confusing, they look complicated, but if you actually just look at them individually, it becomes much easier. So bisphosphonates, they end with nate, okay? Everything is elandronate, amandronate. I can create any word, and if it ends with nate, it's going to be a bisphosphonate in medicine, okay? So what does it do? First of all, there's a nitrogenous and non-nitrogenous. Super low yield in general, but I guess they care about it in Al Faisal University. So both do bisphosphonates do. Now, these osteoporosis drugs come in two forms in general, osteoporosis drugs. They're either gonna prevent the breakdown of bone or they're gonna help build the bone. What's more commonly used is preventing the breakdown of bone. And if you look at here, bisphosphonates, denosumab, raloxifene, these are preventing breakdown. Whereas teriparatide, yeah, that's gonna help build up some bone, okay? So let's start with bisphosphonates. It's going to inhibit the osteoclast. Remember, the osteoclast is that thing that's going to be breaking down. So also is going to inhibit osteoclasts, and there you prevent bone resorption. Okay, how does it inhibit osteoclast? By binding to hydroxyapatite. Hydroxyapatite is something in the bones, and it's a lot. There's a lot of it in the bones. That's why bisphosphonate is going to go mostly to bones. Okay, and it's going to induce apoptosis, which is just self-killing, suicide of the cells. Okay, we'll look into what's the difference between nitrogenous and non-nitrogenous a bit further. Now, a very unique side effect too. One is esophagitis. That's why you have to know that when you're taking bisphosphonates, you have to be seated down 30 minutes at least after you take it, and you gotta drink with a lot of water. Why? Because you don't want it to stay in your esophagus. You don't want to lay down, and it's gonna mess up your esophagus. Okay. Number two is osteonecrosis of the jaw. Okay, you're just gonna come. There's gonna be necrosis of the jaw. Have you ever thought about osteonecrosis of the jaw in medicine anywhere else? No, it's very unique to bisphosphonates. Okay. That's the first drug. We'll go into questions, of course. The second drug is going to be denosumab. If anything ends with a mab, an AB, it's going to be an antibody, monoclonal, bispecific, etc. It's going to be an antibody. You'll see later in other lectures we have rituximab, we have infliximab, adalimumab. These are all antibodies. Okay, monoclonal antibody here. This inhibits rank L. It's similar to osteoprotegrin, preventing osteoclast differentiation. So this is a quick picture. We have here osteoblasts. Osteoblasts are going to secrete rank L. Rank L, follow my mouse. Rank L is going to go here. It's going to bind to rank on pre-osteoclasts, immature osteoclasts. Rank L will bind to rank. This is going to lead to differentiation of immature osteoclasts into mature osteoclasts. And these osteoclasts are going to break down the bone, which is something we don't want in osteoporosis. So in general, in our body, we have something called osteoprotegrin, this OPG thing. OPG, I already have OPG right now, okay? It's going to bind to rank L, and it's preventing the binding of rank L to rank and maturation of osteoclasts. So what these scientists did is that they're like, hey, why don't we make something like osteoprotegrin? And they created something called denosumab, okay? Denosumab is going to be like osteoprotegrin. It's going to bind rank L to prevent rank L binding to rank and prevent the maturation of osteoclast. Now, that one sentence, I can ask you 4 different questions on it. I can tell you what is denosumab like. It's going to be like osteoprotegrin. Number 2, what does it bind to? It binds to rank L. Number 3, what does it do? What does it inhibit? It inhibits the binding of rank L to rank. And number 4, which is the last question, can be, so ultimately what happens is going to prevent the maturation of osteoclasts. Okay, 4 different ways I can ask you one question, and wallah, this is how they do it in USMLE, SMLE, whatever, wherever you want to go. They'll take one sentence and break it down into 4 different ways to ask. That's why you got to understand the whole scenario and not just memorize it, okay, from the beginning to the end. So we go back. It has side effects: hypocalcemia, risk of infections, monoclonal antibodies. Almost all of them are going to have some risk of infection, okay? So hypocalcemia is kind of more unique to these drugs, for denosumab specifically, when you're looking at the osteoporosis medications, and osteonecrosis of the jaw, similar to bisphosphonates, but more commonly with bisphosphonates. Next, we look at teriparatide. Teriparatide is not like the other medications. It doesn't prevent breakdown. It's gonna help build up some bone. Okay, so how does it do that? We already know what PTH is in the body, right? Parathyroid hormone secreted from the parathyroid. Wow, that's so hard. Parathyroid hormone. What does it do? It leads to an increase in calcium and decrease in phosphonate. It kind of breaks down bone, thyroid. However, at a low dose of parathyroid and intermittent prescription, this parathyroid hormone, instead of breaking down, can actually stimulate osteoblast activity and new bone formation. Okay, so what is the idea here? Is that you want to give it at a low dose and intermittently. Why? Because if you give it too much high dose, remember what we said, it's just going to break down the bone. So instead, you want to give it a low dose, teriparatide. That's what it's doing, and it's going to activate osteoblast. So a few questions. So what is teriparatide? It's a recombinant PTH analog. It's like PTH. Remember how denosumab was like osteoprotegrin? Teriparatide is like PTH. It's imitating PTH. However, at a low dose and intermittent activity. Why? Because that can prevent bone formation. Okay. Now, a side effect: osteosarcoma risk. Is okay. It's not really asked about that much, but I've seen it being asked in USMLE about its contraindication in Paget's disease. Okay. Now, the last huge class, okay, raloxifene. It is a selective estrogen receptor modulator, okay? Now, we know that there are estrogen receptors in the bone, and actually that's why osteoporosis is more common in postmenopausal women, because they have decreased estrogen, okay? So what you can do here is that if a decreased estrogen is the cause of osteoporosis, why don't you give something that acts like estrogen? And that's what raloxifene is, okay? So it's gonna act like estrogen here, and it's gonna bind, but it's not gonna agonize everything in the body. It's gonna be a partial agonist and antagonist. It's gonna be an antagonist at the breast and uterus to prevent breast cancer and endometrial cancer. Something I believe the second years might not have taken, so I don't want to go into too much detail about that. And at the same time, it's going to agonize, it's going to activate the estrogen receptors in the bone. And that's going to prevent osteoclast activity, okay? So one of the side effects is venous thromboembolism and hot flashes. Hot flashes, why? Because it's like, yeah. So let's dive into questions. So you can pause the video here, because this is a recording, and you can read the question, answer yourself, and then we'll see what the answer is, okay? Okay, so osteoporosis, teriparatide. Which of the following best describes the mechanism of action of teriparatide? Is it A? A is inhibition of osteoclast activity by blocking rank L. What did we say that was? That was denosumab, monoclonal antibody. So it's not A. B, decreasing bone resorption through selective estrogen receptor modulation. That's not teriparatide. Remember, we said that was the SERMs, the selective estrogen receptor modulators, which was raloxifene, okay? C, stimulation of osteoblast activity by mimicking parathyroid hormone. That is what teriparatide is indeed. D, binds to hydroxyapatite. We said that was what? Bisphosphonates, ends with nates, alendronate, tiandronate, or marandronate, whatever. Okay. Next question. So this is, I already said that. Remember, anabolic agent. Anabolic means it helps build. It's not a catabolism. It's anabolism. Anabolism, whatever. Okay. So next, okay, now this is a question from one of your previous exams. I think so. Yeah. Um, and it looks very spooky, so that's why I wanted to put it in. Even yeah. So let's dive into it. It says she was prescribed ibandronate, whatever. Okay, which of the following? And remember how I was talking about the difference between nitrogenous and post-nitrogenous. Now let's look at. Imagine I was in this exam. Okay, how would I approach this question? I know they're asking about ibandronate. Okay, so let's see E, analogous to osteoprotection. I know that's not right. So I'll cancel out E because that's denosumab. D, expression of multiple estrogen regulatory. I know that's also right, not right. Why? Because that's raloxifene. I'll cancel out D. I'm left with C, B, and A. What's C? Inhibit post-translation lipid modifications. I don't really know what that is that much, so I can't cancel out that yet. What's B? Activate osteoclast to initiate apoptosis. Does that make sense? If you're activating osteoclasts, is that going to lead to apoptosis? Or is that going to lead to breakdown of the bone? It doesn't make sense. Why would you want to activate osteoclast in osteoporosis, right? It's just going to make it worse. So I'm going to cancel out B. I'm left with A and C. Now, from instead of having a 20% chance of getting this question right, now I have a 50% chance of getting this question right because I'm only left with A and C. You got to think with this. You got to use this mentality of crossing out options, okay, in your exams, etc. So let's look at the answer. Let's look at this. It's from your lecture. It looks all spooky, like I said. But like I told you, you want to take things one thing at a time, okay? So here it's saying inhibits post-translation lipid modifications. So something you got to know about ibandronate is that the nitrogen-containing ones are involved in the lipid processing, okay? And they inhibit this enzyme, FPPS, which is like farnesyl pyrophosphate synthetase or something like that. So you have ibandronate, it's going to inhibit FPPS. As a result, you're not going to have this farnesyl pyrophosphate and the I can't even pronounce that. Okay, so you're not going to have these F and Gs. Okay, as a result of that, you're not going to have protein prenylation. So 4 questions I can ask. Number 1, what does it inhibit? It inhibits this FPPS, ibandronate. Number 2, as a result of inhibiting the FPPS, what happens? You have less farnesyl and G pyrophosphate. Okay, and as a result of having less of these, now you cannot have protein prenylation. And you need protein prenylation for osteoclast activity. Okay, so that's it. I took it one at a time and it became so easy. It's something related to mevalonic acid. Okay, HMG-CoA reductase. That's like statins. I don't think second years took that yet, so ignore that. But here, this is the important part. Okay, inhibits FPPS, prevents the formation of farnesyl and GRN phosphorylation. As a result, you cannot have protein prenylation, and you need protein prenylation for osteoclast activity. Easy peasy. I can also, okay, easy peasy, very easy. So that's the answer here, C. It is not A because you'll see, so this is it, okay? The difference between nitrogenous and non-nitrogenous, nitrogenous, and I already explained it to you. Inhibits the mevalonate pathway, okay? Now, non-nitrogenous, what do? They're metabolized. They're metabolized into non-hydrolyzable. So they're metabolized into what? Into non-hydrolyzable ATP analogs. Something like that's like ATP in the osteoclast. However, these analogs accumulate. So I'm going to act like ATP, and now I'm going to build up. As a result of me building up, I'm going to lead to osteoclast apoptosis. Easy. Now just remember, toluidronate is the only non-nitrogenous from the lecture. The rest are nitrogenous. Okay. In the question from the exam was ibandronate, which was nitrogenous. Okay. I told you, take it one step at a time. Be like, okay, this happens, then this happens, then this happens. As a result, what happens? Easy peasy. Okay. Next question. Which of the following mechanisms? Okay, patients prescribed residronate. Explains the drug's effect on bone mineral density. Extremely easy. Decrease osteocyte. Does that make sense? No, it's not osteocyte. It's osteoclast. Clast. Okay. Decreased stimulation. I don't even know what that is. B. Decreased urinary calcium excretion. That's not how bisphosphonates work. Or D. So or F. Okay. So it's gonna be E. Inhibition of osteoclast mediated bone resorption. What is F? Stimulation of pro-osteoblasts to mature I don't even know what that is, okay? So it's E. Easy. Just cancel everything and you're left with one answer that's correct. Inhibition of osteoclast-mediated bone resorption. Next, read the question. And the question asks, which of the following drugs is the most appropriate option to reduce the risk of both bone fractures and breast cancer? Remember what I told you guys, that there was one drug that was unique, that it had something related to bone and uterine, and which was the selective estrogen receptor modulators, raloxifene D, is going to prevent bone fractures and breast cancer. Okay, there, done. We're done with with osteoporosis drugs. Extremely easy, right? Bisphosphonates, denosumab acts like osteoprotein. Remember, bisphosphonates can cause esophagitis and osteonecrosis of the jaw. So as a result, you want to drink it with a lot of water and while you're standing up front. Denosumab acts like osteoprotein, prevents rank L from binding to rank, preventing the osteoclast maturation into mature osteoclasts, okay? Teriparatide PTH analog, low dose, intermittent, it's going to stimulate osteoblasts to create bone. And then we just did raloxifene. Next, we're going to dive into gout. So for gout, the medications, similar idea, mechanism of action, blah, blah, blah. But there's something else you also want to know, is that what do you give first? What do you give second? What do you give in an acute gout? What do you give in chronic gout? Okay? This is all important. And then the unique side effects, as we said. Let's dive into it. So here I give you a big table. And now this table, Allah, it's extremely easy. Like, this is one of the easiest tables I've seen in my life. Why? Because you take it one step at a time. You don't want to see this all and be overwhelmed and like, oh no, I have this. Just take it one step at a time. You start with NSAIDs. What does NSAID do? This, that, blah, blah, blah. Okay? Corticosteroids, colchicine, one thing at a time. Now, this is the boring part of my session, is that I'm going to look at these tables. I'm trying to try and explain it to you. We all know what NSAIDs are, anti-inflammatory. It inhibits COX enzymes, reducing prostaglandin, easy peasy. Now, the important thing is that it's first line for gout. So a guy comes with gout, you have a lot of medications. Unless he has contraindications to NSAIDs, what do you give him? I give him NSAIDs. Okay, but you, Omar, you said unless he has contraindications to NSAIDs. So what are the contraindications to NSAIDs? This is going to be so important for the rest of your life, okay? The contraindications to NSAIDs. The contraindications to NSAIDs is peptic ulcer disease. If the patient has peptic ulcer disease, gastric ulcers, peptic ulcers, blah, 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 stomach ulcers, whatever they call it, you can only give him celecoxib from NSAIDs. Otherwise, you don't give him any NSAIDs. Celecoxib is safe for the stomach, okay? And now, one extremely important thing you also want to know is that although aspirin is an NSAID, you cannot give aspirin. You cannot give aspirin in gout, okay? Why? It can decrease uric acid excretion. And remember, hyperuricemia is one of the causes of gout, so you don't want that, okay? So remember, we said NSAIDs can be our first line. However, you don't give aspirin. At the same time, if he has peptic ulcer disease, you don't give him what? Celecoxib. And another contraindication of NSAIDs is severe renal impairment, okay? Chronic kidney disease, okay? So next, now, okay, Omar, but there are other drugs I can give in gout. Acute gout, if you don't want to give NSAIDs because he has these side effects or because it's so severe, you can give him corticosteroids. Corticosteroids can either be orally, IV, or in the joint. Less likely though. Okay, corticosteroids inhibit phospholipase A2 for acute gout and unique side effects. I mean, eventually you're going to learn about the side effects of corticosteroids. Are also very important because of how much corticosteroids are given in general. It's important to know the side effects. Okay. Next, colchicine. Colchicine is a unique drug, and remember, they like asking about unique things, so they're going to ask you about colchicine. Colchicine is also given in when? It's mostly given in acute gout, okay? Given after NSAIDs and corticosteroids, second line, okay? Some guidelines will say it's first line, whatever. They're not going to ask you too many details about that. What is this mechanism of action? Binds tubulin, inhibits microtubule polymerization. So I am colchicine. What am I going to do? I'm going to bind tubulin. As a result of me binding tubulin, I'm going to inhibit the microtubule polymerization. And as a result of that, I'm going to prevent neutrophil chemotaxis and activity. And why is that important? Because inflammation, gout is inflammation, and neutrophils cause the inflammation. So if I prevent the neutrophils coming to the gout, the joint, I'm going to prevent the inflammation. Okay? Extremely easy. Like I tell you, take it one step at a time, it's going to be easy. What is this contraindication? Severe renal or hepatic impairment. So renal impairment is going to be both NSAIDs and colchicine. Okay? Next, let's dive into the chronic gout. We were talking about acute gout, NSAIDs, corticosteroids, colchicine. And now let's talk about chronic gout. That means, okay, now I'm done with my gout attack. Now I'm at home. I want to prevent future chronic gout attacks. What do I give? The first line is allopurinol. Allopurinol is a xanthine oxidase competitive inhibitor. It decreases uric acid production. It's first line for chronic gout, and extremely important to remember: do not give it in acute gout. Wallah, they ask this a lot on USMLE to confuse you, because allopurinol is that nice sounding drug, oh, gout, but you do not give it in acute. A guy comes to you in the ER, he has gout right now. What do you give him? Do not give him allopurinol. We said we give him NSAIDs, steroids, colchicine. Allopurinol only if he's chilling right now and you want to prevent future attacks. Now, allopurinol side effects: Steven-Johnson syndrome, which I'm sure you've taken in dermatology. And one very important thing, remember how I told you there's unique ideas about these drugs, is that you have to be careful with azathioprine and 6-mercaptopurine when you're giving these drugs as well. Azathioprine and 6-MP are immunosuppressants given in other drugs, in other cancers, blah, blah, blah. And you cannot combine allopurinol with these drugs very well. Why? Now here, let's talk about why. Where is that? Okay, there it is. Here it is. It's right here. So this is azathioprine. Okay. What did we now? Azathioprine and 6-MP, they are metabolized by xanthine oxidase. They are metabolized. So let's say I take azathioprine, la samahullah, and I want to break, and I'm done with the azathioprine. I want to break it down. I need xanthine oxidase to break it down and clear out of my body. Khalas. I don't want it in my body anymore. I want to clear it out. I need xanthine oxidase. But if you give me allopurinol, I'm not going to have xanthine oxidase. You remember allopurinol blocks xanthine oxidase. So if that means I don't have xanthine oxidase to break down allopurinol, to break down azathioprine, it means azathioprine is going to build up in my body, and I'm going to have severe side effects from azathioprine and 6-MP. So that's why you have to be very cautious when you're combining allopurinol and azathioprine. Now, a side note, why would someone combine allopurinol and azathioprine? It's extremely important, actually. I'm not going to dive into the details why, but that happens a lot. You'll see later because of the cancers that are associated and blah blah blah. So like I said, so now imagine I'm taking azathioprine and I need allopurinol. So what I'll do is that I will decrease my dose of azathioprine, because if I take allopurinol, even though this is inhibited, azathioprine is going to increase, but it's not going to increase too much, and I'll have side effects. Okay, so 6-MP azathioprine, be careful when combining it with allopurinol. Now let's go back to the questions. Let's go back to our thingy. Okay, now febuxostat is also a xanthine oxidase inhibitor, but it's non-purine. I don't know what that means. It's on the lecture, so I put it here. Okay, now it's an alternative to allopurinol. So if I give you both allopurinol and febuxostat, what are you going to choose first? You're going to choose allopurinol first, okay? Unless contraindications. Now, febuxostat, a unique thing is that you want to avoid it in people with cardiovascular disease. Cardiovascular disease like myocardial infarction, stuff like that, you want to avoid it in these people. Easy peasy, yeah? It's also xanthine oxidase inhibitor. Now, probenecid is it inhibits URAT and OAT. These are receptors in the kidney that reabsorb uric acid. Now, let's say I don't want uric acid, so I want to inhibit the reabsorption of uric acid into my body. How do I do that? By inhibiting the receptors, the transporters, that bring in uric acid, which is URAT and OAT. Okay, so probenecid will prevent these, and then you're not going to have the reabsorption. It's also used in chronic gout, okay, and it has increased risk of uric acid kidney stones. Why? Okay, I'll just let you know this. I don't think it's really important for this lecture, but for the future, it's going to be important. Step 2, step 1, blah, blah, blah. If I'm preventing the reabsorption of uric acid from the kidney, there's going to be more uric acid in the kidney piling up, and as a result, you're going to have a stone. Common sense, right? Avoiding renal impairment can lead to penicillin toxicity. How can it lead to penicillin toxicity? Let's go back to this lecture, this slide. Remember how I said xanthine oxidase breaks down, blah, 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 so you can't take it with allopurinol. A similar concept is penicillin is excreted through these transporters, URAT and OAT. It's excreted through these receptors. Now, if I'm blocking these receptors, I'm going to have a buildup of penicillin in my body because I'm not going to be able to excrete it out of the kidneys. See? Again, easy. So if you're taking propenicillin and penicillin, I might have penicillin toxicity. PP, propenicillin has a P, penicillin has a P, easy. Now, pegloticase and rasburicase, they are uricase that recombinant uricase that converts uric acid to allantoin for excretion. So it's going to take the uric acid, convert it to allantoin. Okay, it's also used for chronic gout. It's kind of less important than these. Okay, now let's dive into questions. A doctor describes allopurinol. What did we say allopurinol was? Xanthine oxidase inhibitor. D. What is A? Microtubule. Remember, prevents microtubule polymerization. Colchicine. Colchicine is used in what? Acute gout. When? After NSAIDs and corticosteroids. Organic acid transporter, OAT. What was that? Probenecid. Probenecid is used in chronic gout. Cyclooxygenase is easy NSAIDs, which is used in first line for acute gout. Next. Okay. Next question. So he has sudden pain in the middle of the night. Physical examination shows swelling and tenderness of the first metatarsophalangeal joint. That's going to be your big toe, which is the most common area for acute gout. Joint aspiration shows needle-shaped negative birefringent crystals. That's important for pathology. Okay, and that's gout. That's basically gout. So which of the following is the best initial treatment for this patient? And what did we say was the first line for gout, acute gout? We said it was allopurinol. Nope, it's not allopurinol. It's NSAIDs. Exactly. Good. I'm glad you got shocked and you're like, no, it's not allopurinol. Allopurinol, remember, we said we don't use that in acute gout. We use NSAIDs. After NSAIDs, we can use oral glucocorticoid. Okay? Next. So acute gout, non-steroidal NSAIDs preferred first. Okay. So anti-gout medication should not be given in a history with severe renal impairment. So I hope you gave me two answers here, which is both endomethacin and colchicine. Remember, we said colchicine, severe renal impairment, we don't give it, and endomethacin, NSAIDs, we do not give him in severe renal impairment. So here, both 2 and 3 are the answers. I'm trying to confuse you a bit so you can wake up and be like, what's going on, you know? Yeah, allopurinol, remember to be careful when you're giving azathioprine and 6-mercaptopurine. Febuxostat, contraindication was cardiovascular disease. Next. So, a patient is started both allopurinol and azathioprine. What dose adjustment should be used on? Okay. Remember, allopurinol breaks down xanthine oxidase inhibitor. It's xanthine oxidase inhibitor. As a result, you're going to have higher azathioprine. So if I don't want that much high azathioprine, what should I do? I should decrease the dose of azathioprine, which is C. You want to decrease the dose. If you increase the dose, add B moot, and A, you can give them both normally, okay? Because of this reaction I said. Next, arthritis medications. Easy as well. So, as I said, I'm gonna remember, like, if you look at this big ass table, we looked into it, and it turned out to be pretty easy, right? Because we took one step at a time, and we categorized each one: acute, chronic. The ones in a chronic had similar methods of action, stuff like that. So that's how we make pharmacology easier. That's why pharmacology is super easy. So, okay, so we have a few drugs for mostly, I said arthritis. It's more kind of rheumatoid arthritis. Okay, so let's start. Methotrexate, first line medication for the chronic treatment of methotrexate. You know, a patient's for what? For rheumatoid arthritis, I mean, okay? Now, what is the method of action for methotrexate? It inhibits dihydrofolate reductase and thymidylate synthetase. So both these, more commonly, dihydrofolate reductase. As a result, you're going to have decreased purine synthesis and increased adenosine, and this is going to lead to reduced T cell activity. So next, so we were saying methotrexate, okay? It has some side effects, unique side effects, and when you know that it has unique side effects, that's what you're going to monitor for, right? So methotrexate can lead to hepatotoxicity. So it can lead to liver enzymes, elevation of liver enzymes. It can also lead to bone marrow suppression. So if you have less bone marrow suppression, if you have bone marrow suppression, it means you're gonna have less WBC, RBC. So what you're gonna have, you're gonna have infection because you have less WBCs. That's gonna lead to infection. Okay. Stomatitis means like mucositis. It means you're gonna have ulcers in your mouth, in your stomach. Okay, it's gonna lead to ulcers, mucositis. Why? Because it breaks down rapidly dividing cells. I'm sure you've sometimes you've bitten your tongue or your like your cheek when eating, and you'll see that it rapidly regenerates. Why? Because it's rapidly dividing. Okay, so stomatitis, lung disease, okay, can also cause pulmonary fibrosis, and it's very teratogenic, so you have to avoid it in pregnancy. So three things I just said there, and that's what they love asking about methotrexate. Okay, one, you gotta know the method of action. You gotta know it's dihydrofolate reductase inhibitor and also a thymidylate synthase inhibitor, which leads to decreased purine and pyrimidine synthesis. And you're going to have an elevated adenosine. And all of this is going to lead to decreased T cell activation. And you're going to have less inflammation, which is helpful for rheumatoid arthritis. Okay. Now, extremely important side effects for methotrexate is that it can cause hepatotoxicity. So you want to measure the liver enzymes over time. It's also teratogenic, so you have to avoid it in pregnancy and do a pregnancy test. And bone marrow suppression, so the patient is going to be at risk of infections, okay? And pulmonary fibrosis. Next, hydroxychloroquine. Mechanism of action, not that unique. What's extremely important about hydroxychloroquine is that it can lead to retinopathy. It can damage the eyes, okay? So retinopathy, how do you monitor this? Remember how I said for methotrexate, you monitor by looking at the liver enzymes and looking at WBC. For the hydroxychloroquine, how do you monitor? By doing eye examinations. So you do periodic eye examinations for hydroxychloroquine, okay? And it is safe in pregnancy. So one of the unique medications here that's safe in pregnancy is hydroxychloroquine. So these are two questions right here that I can ask you. Unique things, they're going to ask you about that. So that's what you want to remember. Leflunomide, okay, inhibits dihydroorotate dehydrogenase, decreasing pyrimidine synthesis, hepatotoxic and contraindicated in pregnancy. Okay. Sulfasalazine, what's unique about it? Safe in pregnancy as well. Okay. Adalimumab. Now, adalimumab, remember what we said about AB? If something ends with AB, it's a monoclonal antibody. And here, adalimumab is a monoclonal antibody. It's a TNF alpha inhibitor. Remember, TNF is a cytokine, and it's important in inflammation. So if you inhibit it, you're going to have less inflammation, right? And now, an important thing they like asking you about here is that these monoclonal antibodies, they can be either from a human, from a cow, from a rat, from a mouse, blah, blah, blah. Now, adalimumab is a fully human monoclonal antibody. It's all fully human. Okay, unlike infliximab, which is chimeric, which means it's half mouse, half human. Chimeric infliximab. Fully human, adalimumab. Now, something extremely important about. So remember what we said about hydroxychloroquine? Its side effect is eyes, so you want to look at the eyes examinations. Methotrexate, you want to look at liver, WBC. So something in adalimumab is that it can lead to reactivation of TB, tuberculosis. Why? Because TNF alpha is needed in keeping tuberculosis at bay. So if you inhibit TNF alpha, what is going to lead to TB is going to reactivate and lead and disseminate. Okay. So I don't think second years have taken cardiopulmonary, like CVP in third year, which they talk a lot about TB. So I hope I don't make it too صعب on you guys. So yeah, so what do? You have to test for TB. If you want to give adalimumab, infliximab, or etanercept, you have to test for TB. Extremely important. Okay. Now let's dive into etanercept. Etanercept, it doesn't end with ab. So it's not an antibody, okay? Instead, it is a TNF alpha receptor decoy protein. What does that mean? So adalimumab and infliximab are TNF alpha inhibitors. They're going to bind to TNF alpha and prevent it from binding to their receptor. Etanercept, on the other hand, it's going to act like a receptor. It's going to be like, hey, I'm a receptor, but it's April Fool's. It's psych. They're fooling you. It's not actually a receptor. It's a decoy receptor. So TNF alpha is going to come bind to etanercept and nothing's going to happen because etanercept is not actually a TNF alpha receptor. Same thing. It's a TB and it can lead to infections. Okay. Rituximab, extremely easy. You're always going to see this medication everywhere. You want to memorize it from now. It's a CD20 monoclonal antibody inhibitor. prevents B cell activation. And remember, I told you guys monoclonal antibodies can lead to infection. Okay, abatacept, CTLA-4 Ig fusion protein, is going to inhibit CD28 interaction with CD80. So what is that? Let's go into where that is. So here, okay. So if you have, you guys know how T cell receptors have to bind to MHC2 to be activated. That's not the only thing that needs to be that the receptors that can help activate them. You also have these CD28 and CD80 receptors. It's called signaling receptors. One T cell binds to APC is going to lead to activation, even more activation. So you have two different ways to activate the cell. Okay, you need the TCR, MHC, and you also need the CD28, CD80. So what is abatacept going to do? It's going to come and it's going to inhibit CD28. So as a result, CD28 cannot bind to CD80 anymore, and you don't have T cell activation. And we said we don't want T cell activation, and that's going to lead to decreased inflammation. So abatacept binds to CD28, prevents binding to CD80, and great. Okay. Let's go back. So yeah, uh, tofacitinib, if it ends with ib, I'm gonna tell you from now. If it ends with ib, it's either a tyrosine kinase inhibitor or it's gonna be some kind of kinase inhibitor. If it ends with ib, kinase inhibitor. So here is gonna be a Janus kinase inhibitor. Yep, easy peasy. Okay, and now let's start with the first question. Okay, a patient with rheumatoid arthritis, obviously. I mean, she's young, she's middle-aged, worse in the morning, bilateral pain, rheumatoid arthritis. What is the long-term treatment? We said the first one was methotrexate. Methotrexate is the first choice of treatment. Colchicine is for gout. Hydroxychloroquine after methotrexate, sulfasalazine also after methotrexate. Now, steroids are used. Steroids are used in rheumatoid arthritis, but they're used for acute flares. Okay, they're not used long term because they have a lot of side effects. So we said that. So treatment with etanercept is considered. Which of the following tests should be performed? I hope you're pausing the video when you're looking at these. Okay, so okay. So etanercept, what did we say? TNF alpha inhibition, so we need tuberculosis test. When would hepatic function test be right? I hope you're saying methotrexate. When would visual examination be right? I hope you're saying hydroxychloroquine, okay? So etanercept is a fusion protein with domains derived from the FC portion of IgG and TN receptor 2. So it's a TN receptor. That's basically a TNF receptor. Domains derived from it. So it's basically built by this, and that's how it acts as a decoy receptor. Okay, you can read the rest. Next. So she's been taking NSAID, it doesn't help. So liver function tests show AST and ALT are elevated. What does that mean? It means there is hepatotoxicity. And remember, what did we say was the main drug that causes hepatotoxicity? Methotrexate. Good. Hydroxychloroquine is in retinopathy, safe in pregnancy. Methotrexate is bone marrow suppression, hepatotoxicity, painful mouth ulcers. Remember, I told you stomatitis, mucositis, mouth ulcers. That's how it's going to present. And they can also have infections due to bone marrow suppression, and you're going to see decreased WBC counts. Okay? Abatacept, remember, it can lead to tuberculosis reactivation. Naproxen is an NSAID. It can lead to, renal impairment and gastric ulcers. Prednisone is a steroid. You can read this later on. Hydroxychloroquine, what should be done? Eye examinations. Lovely. And we said what inhibits CD28, CD80 binding? Abatacept. Okay. Infliximab antibody, it prevents TNF alpha binding to its receptor. TNF alpha inhibitor. Etanercept was a decoy protein. Adalimumab was what? It's also same as infliximab. It inhibits the binding of TNF alpha to its receptor. What was the difference between adalimumab and infliximab? Remember, adalimumab was a fully human monoclonal antibody, where infliximab was chimeric. It was half mouse, half human. Tofacitinib ends with ib, so it's a kinase inhibitor, Janus kinase inhibitor. Ib, and kinase inhibitor. Let's go. Myasthenia gravis. We're zooming, boys. Okay. So myasthenia gravis, now it's very easy because there's only like a few things you need to know. One you need to know is how do you, the most main drug that's given, and its side effects and the mechanism of action of that drug. Okay. So now this picture is extremely low quality, but it's the best picture I could find online, honestly. So what is you have to know the pathology of myasthenia gravis. That's the first thing. In order to understand how pharmacology works, you need to understand the physiology and pathology. So we know that in myasthenia gravis, you're going to have antibodies to the receptor of acetylcholine, right? So it means you're going to have less binding acetylcholine to muscle receptors, and you're going to have, weakness, blah, blah, blah. Now we generally have an enzyme called acetylcholinesterase. If it ends with ACE, it means it's a breakdown. What is the acetylcholinesterase breaking down? I mean, it's in the word. It's breaking down acetylcholine. So it's going to decrease acetylcholine even more. How do we combat this? By giving an inhibitor of acetylcholinesterase. If I inhibit acetylcholinesterase, I'm going to have greater levels of acetylcholine. I'm going to have more acetylcholine binding to its receptors, and I'm going to have more activation of the muscle. That's what I want. Now, how do I inhibit acetylcholinesterase? By giving pyridostigmine or neostigmine. These are acetylcholinesterase inhibitors, and they're going to lead to an increase in the levels of acetylcholine, okay? So let's look at the first question. Okay, so a patient with myasthenia gravis, pyridostigmine, is it direct agonist at acetylcholine receptors? No. If it's a direct agonist, it means that we go to the receptors and it would bind there, but that's not how it works. Inhibits acetylcholinesterase enzyme, yes. Remember, that's what I said. It inhibits this enzyme, and you're going to have elevated acetylcholine. Acetylcholine receptor antagonist, that's just going to make it worse. So that's not the answer. Okay, so we said myasthenia gravis, you want to know the medication, you want to know how it acts, and you want to know the side effects. Side effects are extremely important. Now, if you think of pyridostigmine, what is it doing? It's increasing acetylcholine. So the side effects are going to be related to an elevated level of acetylcholine in the body. And remember, acetylcholine is mainly for the parasympathetic activation. So how do you memorize the side effects of pyridostigmine, neostigmine? It's by knowing what happens when you have an elevated level of acetylcholine. So let me explain to you how to understand the difference between what happens when you have too much acetylcholine. Okay, cholinergic crisis. So remember, now let's relax a bit and listen up closely. Listen to me, okay? My body is either in the parasympathetic state or sympathetic state. Sympathetic state, also known as fight and flight, and parasympathetic state, known as to relax. Okay. 1 second, guys. Sorry. So now just remember, there are a few things that are gonna change when you're either relaxed or you're in a fight or flight mode. What are those few things that are gonna change? It's gonna be one, your pupils. Number two, it's gonna be your heart rate. Number three is gonna be your lungs, the bronchospasm, the smooth muscle. Okay. Number four is gonna be your bowels, whether they're active or hyperactive. And number five is gonna be your urinary bladder, whether it's gonna be active or hyperactive. And number six, your sweat glands. Are you gonna be sweating more, or are you gonna be sweating less? So what did I say? I said when you're in a flight or fight mode, or when you're in a rest and relax mode, these are the things that are going to change. Your pupils, your sweating, your bowels, your urinary bladder, your heart rate, and your smooth muscle in your lungs. Okay, your breathing. So now just imagine, I see a tiger in front of me. I want to run away from this guy. I can't fight him. So am I going to be in a fight or flight or in a relax mode? Fight or flight, obviously. So in a fight or flight mode, is my heart rate going to be higher? I'm sure you guys have been stressed. You feel your heart rate higher, right? So in a fight or flight mode, your heart rate's going to be higher. When I'm running away from the tiger, do I want to breathe in more? Yes, I do. I want to breathe in more. So what's going to happen to your bronchioles, your smooth muscle? It's going to be dilated, okay? So you can bring in more. You have smooth muscle dilation, bronchial dilation, okay? Number three, your sweat glands. When you're exercising, when you're running, what happens? You sweat more, right? So our patient's gonna be like, damn, I'm sweating more. Okay. Number four, eyes, the pupils. Is it going to be constricted or is it going to be enlarged? Think about it. If I'm running away from a tiger, I want to look at the obstacles around me so I don't trip over something. So I want it to be larger. I want it to be mydriasis, dilated. I want my eye pupils to be dilated so I can be like, hey, I don't want to fall over this tree when I'm running away from the tiger. If my pupils are constricted, I can't see as much. I'm gonna be blurry. I'm gonna have blurry vision, and now I'm gonna fall over a tree and get killed by a tiger, right? Now, bowel and bladder. Imagine you're running away from a tiger. Is that a good time to be taking is that a good time to need to use the bathroom? No. So you're going to have decreased bowel movement, aka constipation. What about your bladder? Same thing. You don't want to pee right now. It's not a good time to pee. So you're going to have uh, decreased urination. Okay. And one other thing is salivation. Salivation is easy to remember. So, because, okay, before I go into salivation, I gave you everything about the sympathetic, fight or flight. On the other side is going to be the parasympathetic. Everything opposite is going to be the fight or relax mode, the relax mode. It's when I want to eat, when I want to sit down, relax. I'm going to have decreased heart rate. My bronchioles are going to be constricted. My eyes are going to be constricted. I'm not going to be sweating. I'm not going to have constipation because now is the time to use the bathroom because I'm relaxed. And I'm going to be able to pee because now is the time to pee. Okay? Also, salivation is also important. So when you want to eat food, you salivate, right? Because that's you're getting ready to eat. So that's easy. So fight or flight mode is going to be less salivation, dry mouth. On the other hand, when you're relaxed, you're going to have more salivation. Okay? So read this question. He took an overdose of pyridostigmine. What are you going to see? Pyridostigmine was, remember, more acetylcholine. Acetylcholine is what? Parasympathetic. So you're going to have things that are going to make you more relaxed. Okay? And what did we say? Urinary retention. No. When I'm relaxed, I want to piss. I want to pee, sorry. I want to let it all out. I'm not going to be constipated. I want to let it out. I want to go to the bathroom. Mydriasis. I don't need to be dilated. Bradycardia. When I'm relaxed, I want my heart rate to be less, so bradycardia makes sense. Okay? And now this is extremely important to know. This is very important to know because they will confuse you between having a cholinergic crisis, which is a side effect of overdosing on medication, or your medications aren't working and you have a myasthenia crisis. It's going to be the opposite. Okay? A myasthenia crisis means you don't have enough acetylcholine, so yeah. Now let's move on. Drugs used for skin infections. Okay? Like I said, method of action, unique side effects, blah, blah, blah. Something for skin infections is that you also need to know when do you use what? When do I use this medication? When do I use this medication? Okay? So this is it. We take it one step at a time. So they have a condition called impetigo. Impetigo can be bullous and non-bullous. Impetigo, it's described usually in younger people, sometimes in middle age, is they're going to describe oozing crusts, honey-colored, yellow-colored, okay? If they're, okay? So if it's localized, like only here, only on my nose, or only on my cheek, I can just put a cream there. And that's when topical mupirocin is going to be used. If it's diffuse, if it's all over my face, all over my hands, I'm putting so much cream everywhere. So I'll use what? An oral penicillin, flucloxacillin. Okay? What is the mechanism of action of mupirocin? Inhibits bacterial blah, 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 halting bacterial protein synthesis. Good luck memorizing this. You have to memorize this, okay? Mupirocin is actually high yield. I've seen it come in USMLE as well. They confuse you between when do you put topical, when do you give oral, and the answer would be here, okay? Cellulitis is a more severe infection, okay? Infection of the subcutaneous tissue. Flucloxacillin, if it's methicillin sensitive. Staph aureus and vancomycin if it's resistant, okay? And I mean, you guys can look through this, okay? Herpes, acyclovir. Now, something extremely important about acyclovir is that one, it inhibits viral DNA polymerase, but also it's activated by viral thymidine kinase. So the virus herpes has an enzyme called thymidine kinase, okay? The enzyme thymidine kinase is actually going to activate acyclovir. Now, why is that important to know? Can I give acyclovir to a virus that does not have thymidine kinase? The answer is no. You can't give it because it's not going to work. Okay. So that's important. So what's a way for a virus to become mutated? By kicking out, by not using thymidine kinase anymore, for example. Okay. So acyclovir activated by thymidine kinase inhibits viral DNA polymerase. Now, topical terbinafine versus azoles, extremely important for tinea infections. Terbinafine inhibits squalene epoxidase, blocking ergosterol synthesis. We're going to see all of this later on, okay? Now let's dive into questions. This is just a summary for you guys, but I think when you see the question and the figures I have, it's going to be easier for you guys. So first question, we said impetigo, localized. Where does it say? Around his nose. Well, that's localized. So do you want to give oral antibiotics and cause side effects? No. So you will give him topical mupirocin, okay? Oral acyclovir is for herpes. It's for virus. It's not for bacteria. Cyclovir and impetigo is caused by bacterial infections, okay? Now to hydrocortisone, that's a steroid. And look, this is from Ambos. Any form of impetigo with a limited area, you give mupirocin. On the other hand, if you have impetigo with large bulla or widespread, you give flucloxacillin. Okay? Great. So painful sores on a lips reports a history of similar episodes occurring periodically, especially during periods of stress or illness, vesicular lesions, and crusted ulcers. When you see a middle or young patient and she has these lesions around her lips that come and go, come and go, come and go, they're recurrent, and they especially happen during stress, and they're described as vesicular, that's herpes. على طول herpes. Vesicular, recurrent, during stress, herpes. Okay? What did we say inhibits herpes? Acyclovir. The rest is all antibacterial medications. So remember, what did I tell you guys? Acyclovir, it's activated by herpes virus specific thymidine kinase, and then it's going to lead. So acyclovir is going to be phosphorylated to monophosphate, and this is the herpes simplex infection. Okay. So here next. So an itchy rash on the sole and sides of his left foot. That is basically a potassium hydroxide preparation of skin shows segmented hyphae. That means it's a fungal infection. When it's a fungal infection around the sole and sides of the foot, that's a tinea infection. Okay, tinea, it can be tinea capitis, tinea purus, around tinea, whatever, onychomycosis. Okay, that's when it's around the nails, and that's all fungal infection. You can give terbinafine. Okay, how does terbinafine act? Is it interrupting bacterial cell wall? No, because it doesn't work on bacteria. It works on this. Okay, so terbinafine inhibits squalene epoxidase. So the answer is going to be B. It's going to inhibit squalene epoxidase. As a result, you're going to have elevated squalene, and squalene is toxic, so it's going to kill the cell. At the same time, I can ask you a question. What does squalene epoxidase? What does this lead to? A decrease in ergosterol, and you need ergosterol for what? You need it for the cell wall, okay? So you're gonna have two things. I'm gonna have less ergosterol, so I can't make cell wall anymore. And at the same time, I'm gonna have elevated squalene, which is gonna lead to toxicity and death of the cell. Okay? What is CYP 450? You're gonna see this later. So this here is scabies, okay? When it's extremely pruritic rash, you also see it in who? And it's also spread out in the family, sister and brother. It's around the hands and the feet. Okay, that's scabies. How do you treat scabies? You can give a topical permethrin or oral ivermectin. Here, topical permethrin or oral ivermectin. Now I can change this question and ask you, what is the mechanism of action of permethrin? Okay, and let's go back to our lovely table. Permethrin disrupts sodium channel function in parasite neurons, causing paralysis and death. Ivermectin binds glutamate-gated chloride channels. So permethrin is sodium channels, ivermectin is chloride channels, okay? And it leads to paralysis of this. It's extremely important. Remember, permethrin sodium, ivermectin glutamate-gated chloride channels, okay? Lovely. Now, one last thing, very important, is that you should remember the method of action of fluconazole. Azoles bind, they inhibit this thing, enzyme, which leads to blocking ergosterol synthesis. And what did we just say ergosterol synthesis is used for? Ergosterol is used for fungal cell wall, remember? The same thing in terbinafine, okay? So now if I inhibit this enzyme, okay, I can't make ergosterol synthesis and I'm gonna have disrupting the fungal cell membrane. So that's how I ask you a question. First question is what enzyme does it inhibit? The second thing is what does it lead to? A decrease in ergosterol synthesis. As a result, you're gonna have cell wall death, okay? Next, acne. Extremely easy. I mean, Dr. Dana Bakhit's lectures are always easy. I remember she's a very nice doctor. And her questions are also very high, they're high yield, and she only focuses on things that are like, colored with green, because those are the most important things. So this is a summary I made for you. You need to know what do you start with. You start with when topical, and then you give oral because oral is going to have more side effects, blah, blah, blah. You want to know that vitamin A derivatives like tretinoin and adapalene, okay? They're used first line, and they're also combined with benzoyl peroxidase. Okay, same now. Topical antibiotics is going to be clindamycin. It's going to kill this bacterium. You don't want to give oral clindamycin because it has a bit more side effects. Instead, you can give oral tetracycline and doxycycline. Okay. Now, sometimes you will combine these oral antibiotics with benzoyl peroxidase. Why? So I can prevent antibiotic resistance. Okay. So that's one question. So why is benzoyl peroxidase given? To prevent antibiotic resistance. Why is benzoyl peroxidase given? And to prevent antibiotic resistance. Now, one thing about oral retinoids, isotretinoids, I'm sure some of you have taken it, extremely important. Remember methotrexate for rheumatoid arthritis. We said we have to monitor liver function, WBC function. For hydroxychloroquine, we said we monitor the eye. For oral retinoids, it can cause also hepatotoxicity. So we have to monitor hepatic function, and it can lead to hypertriglyceridemia. So we have to monitor the lipids. And at the same time, it is teratogenic. So three things: pregnancy test because it's teratogenic, lipid test because it can lead to hypertriglyceridemia, and liver function tests. Why? Because it can be hepatotoxic. So oral isotretinoids, three things: pregnancy test, lipid test, and liver function tests, because these are the side effects of oral retinoids. Okay. So what should be ordered on isotretinoin? All of the above, all of these, okay? All of these. Next, psoriasis, okay? Psoriasis, topical, you can also give topical retinoids, which is tazarotene, okay? Topical calcineurin inhibitors and topical PDE4 inhibitors, okay? So tazarotene is the high-yield dog. She's also colored green. It can cause irritation. Why is that important? Because that's a side effect. What's the side effect? After tazarotene, it can cause irritation, so you combine it with moisturizers. Now, topical calcineurin inhibitors, tacrolimus, pimecrolimus. This is more a high yield in renal transplant medications because it's given orally for renal transplant. Now, I can ask you a question. What is the method of action? Three things. It binds to FKBP12. So the first question is, what does it do? It binds to FKBP12. As a result, it inhibits what? It inhibits calcineurin. So first thing, it binds to FKBP12, and then as a result, it inhibits calcineurin. As a result, you're going to have less IL-2 release. So three different things, okay? FKBP12, calcineurin, IL-2 release, okay? It can be used for sensitive areas like the face. And yes. Third is roflumilast. You inhibit phosphodiesterase enzyme and you elevate leads to increased CAMP. So now I'm going to ask you a question. Which medication inhibits phosphodiesterase enzyme? Roflumilast. As a result of that, what happens? You're going to have elevated CAMP. If you have an elevated CAMP level, it's going to reduce pro-inflammatory cytokine production, okay? Now, what did we say a side effect of tazarotene was? Skin irritation erythema, discoloration, and burning sensation. Okay, because what tazarotene, that is what's it called? Skin irritation, erythema, discoloration, or burning sensation. Now, next one also important thing in this question, when you have diffuse psoriasis in a lot of places and it's not getting better with topical treatment, you can initiate oral systemic treatment like methotrexate or cyclosporin. Okay, see, methotrexate, cyclosporin, you can use it as oral treatment as well. In what? In severe psoriasis. Okay, severe psoriasis, methotrexate, cyclosporin. Okay. Now, last thing, joint infections, bone and joint infections. Now, bone and joint infections, usually infections in general, the way they ask you about these medications, these things, if you remember this for the rest of your life, for second, third, fourth, and fifth year, number one, you have to know the method of action. Number two, you have to know unique side effects. Number three, you have to know unique bacteria that are going to be targeted by this drug. Like, and I can take one bacteria like amoxicillin. It can target multiple bacteria. So I'm not going to ask you about that. Haram. But instead, Pseudomonas, there are only unique medications that can target this drug. So as a result, you need to know all the medications that target Pseudomonas. Extremely important. You're definitely going to get that in step 2 at least, and clinical years as well. So let's start. Remember, I gave you mechanism of action and the medication. Okay? So this is extremely important. 100% extremely important for step 1. Okay, so Vancomycin, two things. One, it inhibits cell wall synthesis. Okay, great. But penicillins also inhibit cell wall synthesis. So how can I differentiate between them? Vancomycin will bind to D-ala terminus of peptidoglycan precursors. Okay, peptidoglycan. They always ask that in vancomycin. They will mention peptidoglycan somewhere in vancomycin. Compared to cephalosporins, it's going to bind to penicillin binding proteins. Okay, penicillin binding proteins here is D-ala. Okay. Levofloxacin and ciprofloxacin, they will inhibit DNA gyrase and topoisomerase in DNA replication. Clindamycin, 50S, 50S, 50S. Just remember 50S, okay? 50S. Linezolid, 50S as well. 23S, blah, 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 50S. Remember 50S, honestly. So clindamycin, linezolid, 50S. Levofloxacin, ciprofloxacin, these are fluoroquinolones. They inhibit DNA gyrase and topoisomerase, and the rest is easy, okay? So we said vancomycin, cell synthesis, D-ala. Cephalosporins, penicillins, penicillin binding protein, cell synthesis. Fluoroquinolones, DNA gyrase and topoisomerase, they're the same thing, I think. Yeah. Clindamycin, 50S, linezolid, 50S. Now remember here that levofloxacin and ciprofloxacin cover Pseudomonas as well as ceftazidime and cefepime. This is you have to memorize. 100% you have to memorize this. Ceftazidime, cefepime, and fluoroquinolones cover Pseudomonas. Okay, from these few medications. I think even linezolid covers it. You'll have to double check that yourself. Okay. Bacteria, medication in the darkness 50S. What is that? Clindamycin. Ceftriaxone is not 50S. Ceftriaxone is the cell wall synthesis. Levofloxacin is DNA gyrase and topoisomerase. Vancomycin also cell synthesis. So the only one that's ribosomal 50S is clindamycin here. Okay. And also, something you need to know is what is the first line treatment you give? Remember how gout, we said the first thing you give is NSAIDs, right? Rheumatoid arthritis, long term, what do we give? Methotrexate, right? What about in an osteomyelitis patient? In general, if I have an osteomyelitis patient, ignore this question. I'm talking. And you're suspecting MRSA, which is methicillin resistant, you want to give him vancomycin. Vancomycin is the big gun. Everyone loves it. It's a big gun. Okay, it targets methicillin resistant Staph aureus, and it's almost always given in empirical therapies in many infections, except for unique areas when you're assuming it's more likely to be gram negative, because Staph aureus is gram positive, right? Now let's look at here. Sickle cell disease, okay? So if I want a sickle cell, what is unique to sickle cell? Is that they also have, in sicklers, salmonella is the first line treatment. Salmonella is a bacteria that can damage this, okay? So salmonella is gram negative. Vancomycin does not work against gram negative. It works against gram positive, right? So in a sickle cell disease patient, will Vancomycin targets salmonella? No. Ciprofloxacin is going to be the answer because ciprofloxacin is against salmonella. Now you might be confused here. Okay? I like confusing you a bit because that wakes you up here. But Umar, Staph aureus also can happen. You can also have Staph aureus in sickle cell disease. And we said vancomycin targets Staph aureus, right? So shouldn't it be both A and B? And that can definitely be a correct answer. Vancomycin can also be the answer here. So inshallah, they will not likely give you both A and B because both of them can be correct. Vancomycin, I mean, even in a sickle cell patient, even if you're assuming salmonella, he can also have Staph aureus. And you want to cover that Staph aureus with vancomycin, for example, okay? So, but it's definitely not C or D. It's definitely not amoxicillin. Amoxicillin does not kill MRSA and not D, okay? So what did we say? Sickle cell, salmonella, ciprofloxacin. Next, what did I say was the first line treatment in osteomyelitis patients? Vancomycin. Okay, this is a patient with osteomyelitis. What is the initial empirical antibiotic therapy? Vancomycin for sure. Not amoxicillin. Fluconazole is literally fungal, and azithromycin is macrolide meh. It's not that good for MRSA. Okay, so vancomycin is the big gun. Empiric therapy. That's it. That's it for my session. I hope it's like only 1 hour long. Remember, there was one part I paused because someone came in. Sorry for that. Just make sure you skip that part. If it's still in the video, I might edit it out. Now, if you have any questions, feel free to contact me. If I confused you anything anywhere here, or if there are some things you want to ask about, contact me, email me, WhatsApp, whatever. Inshallah, I'll get back to you. Especially second years, I'm sure it's a bit harder for you guys. Don't worry. Inshallah, it'll become easier. Repetition, do questions, use resources, resources outside of the lectures as well. And that's it. Thank you very much for listening, and good luck. And see you inshallah in another episode. Ma salama.